Welcome to those who have joined us. Let's just wait a few more seconds. Okay, I think we'll get started. Welcome everyone, happy September, and I hope wherever you are that you're ready to jump into the fall, which starts tomorrow. Today we have Dr. Anna Maria Vranceanu presenting the nuts and bolts of behavioral intervention development. Just a few housekeeping items. All attendees are muted and video cannot be turned on. However, we do wish for you to engage with us by using the chat for your thoughts and the Q&A feature for your questions, which we will have at the end of Dr. Vranceanu's presentation. So along with our panel is also Dr. Christine Ritchie, representing the PCRC's Executive Committee. And so I'd like to turn it over to Dr. Ritchie and have her please introduce our speaker.
Thank you, Naomi, and greetings, everybody. I can't tell you what a joy it is to have this opportunity to introduce Dr. Anna Maria Vranceanu. And this will not give her enough credit for all the amazing work that she's done, but I'll just give you just a little thumbnail about her. She's a clinical health psychologist. She directs the Center for Health Outcomes and Interdisciplinary Research in the Department of Psychiatry Hospital. She's also the James and Elizabeth Gamble Endowed Chair and co-director for the Mass General Neuroscience program and is Associate Professor of Psychology at Harvard Medical School. She is intervention development, especially intervention development of behavioral health interventions for patients, caregivers, patient-caregiver dyads, and all with the goal of either preventing illness, optimizing recovery after illness, or promoting wellness for people who are living with persistent or serious illness. She has a very large array of federally funded trials that focus on pain management, on chronic emotional distress among patient-caregiver dyads after acute brain injury, addressing chronic pain and early cognitive decline in people living with dementia, and also a physical activity intervention for older Black adults in Boston area churches. She is an awesome mentor. She's very passionate about mentoring. She has a K-24, and she also leads a wonderful K Club here at MGH, which is very well subscribed and people learn greatly from. So you now have the opportunity to learn from Dr. Vranceanu about the nuts and bolts of behavioral intervention. Thank you so much, Anna Maria, for being a part of this webinar series.
Thank you so much, Christine, for the wonderful introduction. You didn't say that we get to work together on a lot of these projects, which is wonderful. I am very happy to be here with all of you to talk about behavioral intervention development. I have been developing and testing behavioral interventions for over 15 years now, and have benefited a lot along the way from the wonderful PCRC resources. So I'm often teased by family and friends for reading the last page of a book first. I find that this often piques my interest and allows me to better grasp the content and enjoy the process. So today I will start with the end in mind, with the main message I hope to convey through this talk. I hope to convince you that behavioral intervention should be part of regular care for people on the continuum from health to illness, that behavioral intervention development for patients with medical illness and caregivers requires interdisciplinary collaborations. And I may be biased, but I think a psychologist on the team is always great. It requires frameworks, theory, conceptual models, feedback from all stakeholders, a focus on hypothesizing and testing mechanisms, a focus on implementation from early phases, and careful selection and mapping of measures. And from my experience developing interventions and mentoring others in intervention development, I truly believe that experiential learning is extremely important, and that working as part of one or more intervention development projects alongside someone experienced is extremely useful. So before we get started, I would like to draw attention to 3 wonderful talks given through the PCRC that you may want to listen to. In 2015, Frank, Keith, and Tammy Sommers, 2 wonderful psychologists within the PCRC community, presented on the process of intervention development. In 2019, Frank, Keith discussed novel behavioral interventions in palliative care. And finally, a few months ago, Joe Winger, Greg Cienza, and Tammy Sommers gave a wonderful talk on designing persuasive psychosocial intervention pilot studies. So my talk today is building on these presentations, but does not overlap in content. So in our time together today, we will talk about why behavior and behavioral interventions are important, discuss how to plan for developing a behavioral intervention. We will discuss the goals of behavioral interventions, frameworks or models for behavioral health intervention development and testing. We will discuss in detail the NIH stage model. We will talk about how to know when to move from intervention development to testing efficacy. We will touch upon the importance of understanding and testing mechanisms of interventions, as well as the importance of mapping measures of outcomes and targets or mechanisms onto interventions development. I will also walk you through the development of a behavioral intervention, and we'll end with thoughts on the future of behavioral health and conclusions. And hopefully I'll get to answer a lot of your questions. So why do we care about behavior and why do we care about behavioral intervention? And I'm going to pause for a minute for all of us to reflect together on this. So in 2007, Schroeder wrote an opinion piece in the New England Journal of Medicine where he made the case for the importance of behavior and behavioral interventions. And he showed that the risk of premature death in the US is determined largely by behavioral pattern. And if we think about it, behavior is involved in all aspects of our lives, including medical care. We can have the best drug or the best vaccine, as we have seen with COVID, but these don't do anything if we can't engage people to be adherent to medications or to uptake vaccines. And we can think similarly in terms of advanced care planning or communication intervention, not to mention our palliative care interventions. Yet, when we think about how care is delivered in primary or specialty care practices or clinics, behavior is not often addressed or assessed. And I like to think about the role of behavioral interventions broadly across the continuum from health to illness. I think we need behavioral interventions for healthy individuals to preserve and promote health and prevent illness. For example, we may be able to prevent strokes or diabetes and so many illnesses through lifestyle interventions. We need behavioral interventions for people who are at high risk to preserve and promote health and prevent illness. These are individuals who are under a lot of stress, such as minoritized individuals or informal caregivers of patients with chronic or serious illness. These are also individuals who may have an acute injury or illness where we can prevent transition to chronic symptoms or chronic emotional distress. And of course, we need behavioral interventions for people with chronic or serious illness to preserve quality of life and help them to live well and die well with serious illness. So as we consider whether or not to develop a behavioral intervention, it is important to think through several questions. So first, do we need another intervention and why? In other words, what are the interventions that are already available? What are their pros and cons? And how we might improve upon these interventions. This can also help us decide if we want to develop a new intervention or adapt an already existent intervention. What is the intervention going to accomplish? Improve quality of life or decrease caregiver burden or increase communication? It is important to be very specific about the primary and the secondary outcomes because no intervention is able to change everything. what is the hypothesized mechanism of the intervention? And we will talk a lot more today about mechanisms, but it is important to have a theoretical understanding of why an intervention might work. Who is the study participant? Are we targeting patients or caregivers or dyads? How about other stakeholders who are going to be impacted by the intervention? So for example, if we are developing an intervention in an ICU, the intervention will impact the ICU staff. And so we need to consider how we might be able to involve them in the intervention development process. Who do we need to develop the intervention? So what is the expertise that we have and what additional expertise is needed? So as a psychologist, if I want to develop a dementia palliative care intervention, I know that I have the methodological expertise with this population and have worked with caregivers of dementia patients to address emotional distress. However, I absolutely need a geriatrician and a palliative care doctor who works closely with dementia patients and can bring in that particular expertise. I may also need a neuropsychologist if I'm measuring cognitive decline, and I would benefit from so much expertise from social workers or other stakeholders who are involved in dementia care. What resources are needed? Obviously, developing interventions is expensive. So are there grant money available? Also, what are my resources for recruitment? Am I connected with any patient and caregiver networks? How can I ensure that I can recruit a diverse sample? We know that most research to date has been focused on white individuals, despite the incredible growth in the diversity of the US sample. And so we really need to be careful about this from or early in the intervention development process. And finally, what is the long-term vision of the intervention? If we want to implement the intervention as we should, we need to think about implementation early in the intervention development process, so that we don't develop an intervention that is going to stay on a shelf because it's too complex or too expensive to be implemented. So when we think about the development of behavioral interventions, the goals are to develop interventions that are feasible, meaning people will sign up, that are credible, so that when people see a flyer with a study or learn about the specifics of the intervention, they believe that that intervention will help them. We need interventions that are acceptable so that people will sign up, but also finish all or most sessions. We need interventions who are tailored to address the specific population needs. Of course, we need interventions who have efficacy, that show improvement when compared to a control, that are durable, so improvements maintain over time, that are effective, so they work in real-world settings, that are scalable, that they can be delivered with fidelity across multiple settings, and that are principle-driven, meaning that we have a clear understanding for why, for whom, and in what circumstances the intervention works. And of course, we want interventions to be cost-effective so that the intervention is justified given the cost. So once we decide on developing an intervention, it is important to follow a framework or a model. And I like to think of frameworks or models as navigation systems that help us get to where we want to go. And there are multiple models and frameworks available. The three below are most common: the NCCIH model, the Orbit model, and the NIH stage model. So no one is better than the other, and which framework you choose depends on your own preferences as well as the funding agency where you are submitting your grant application. It's really like picking between Waze, Google Maps, or MapQuest. They all get you there, but you need to use one of them so that you don't get lost. And I will spend more time today explaining the NIH stage model because this is the model preferred by both National Institute of Aging as well as NINR, which are the biggest funders of palliative care research. So over the past years, there has been an increased focus on understanding and testing mechanisms of interventions. And this is because a lot of the time we develop interventions, but we do not know why and how the intervention works. And if we understand how and why an intervention works, then we can ensure that the intervention works consistently and that it can be delivered with high fidelity across settings. And the Science of Behavioral Change is a wonderful NIH-funded organization that has great information and guidelines around how to identify what is the most likely mechanism to investigate, how to measure the mechanism reliably, and whether an intervention can reliably change the identified mechanism. So let's say that we design an intervention to improve depression by teaching mindfulness. If we can measure mindfulness reliably with the 5 facets mindfulness scale, we can demonstrate that the intervention leads to change in mindfulness, and that this change in mindfulness is associated with change in depression, then we know that mindfulness is the mechanism. If we know this, then we can be sure that as we disseminate the intervention, we ensure that the mindfulness skills, not other components of the intervention, are going to be prioritized when the intervention is delivered, because we know that mindfulness is the active ingredient that leads to change in depression. So as I mentioned, the NIH stage model is the most widely used model, and it is a must for all applications at National Institute of Aging. It has 5 stages. Stage 0 is basic science. Stage 1 is intervention generation and refinement. Stage 2, efficacy testing in a research setting. Stage 3, also called the hybrid efficacy effectiveness trial, which is efficacy testing in a clinic or community. Stage 4 is effectiveness research, and stage 5 is dissemination and implementation. And as we go through stages from 0 to 5, external validity increases and internal validity decreases. And I want to spend most time today talking about stage 0 and 1, which are really the crux of intervention development. Before I talk about stage 0 and 1, it is important to mention that the NIH stage model is nonlinear, meaning that you do not need to move from stage 0 to 5. It is iterative, meaning that there are multiple revisions for the intervention as well as the protocol. And the newly revised 2022 NIH stage model also now highlights the importance of hypothesizing and testing mechanisms along the 5 stages, moving away from developing interventions that work for only one disease and thinking about transdiagnostic processes common across diseases, and focusing on implementation from the early stages of intervention development rather than just developing an intervention and worrying about implementation only in stage 5. So stage 0. Stage 0 is called basic science, and the goal here is to identify potential mechanisms for your intervention. And these mechanisms can come from neuroscience, from animal studies, or clinical observations. Here we learn about the literature. A lot of the times it's helpful to do a systematic review or a prospective cohort study to understand the trajectory of the problem that we are trying to solve. And in stage 0, we also solidify our theoretical models as well as start thinking about our conceptual model. And these two are often confused. So a theoretical model is a guiding model, say the biopsychosocial model of disease or the theory of behavioral change, versus a conceptual model, which is a model that you will eventually get to test in your efficacy trial, a model that directly links your intervention to the specific mechanisms and your proximal and distal outcomes. So stage 1 includes the development and optimization of the intervention. Stage 1 development, 1A, includes qualitative interviews with stakeholders, the development of an outline and manual, procedures, screening, measures, as well as team. Often includes a non-randomized feasibility trials, or a lot of the times people just run the intervention within more than one pile to try to refine it. It's very helpful to have exit interviews at the end of this open pilots to really get qualitative feedback from the participants to inform revisions. And very important, consistent with a revised NIH stage model, you need to assess target engagement in stage 1A, meaning you need to show that your intervention, even with a small sample size, is associated with some kind of change in the hypothesized direction in your mechanistic targets or potential mediator, which you will test in future stage 2 trials. And in stage 1B, You conduct a feasibility RCT where the actual intervention is compared to a type of control. And this is really a test before the true efficacy trial. And across stage 1A and 1B, the goal is to maximize feasibility, acceptability, credibility, fidelity, and signal of improvement, and think about mechanisms, potential implementation, as well as scalability. So how do we know when to move from intervention development, so from stage 1 to stage 2 efficacy testing? This depends on whether or not benchmarks are met. And the benchmark you set for intervention will really depend on the population you're working with. These are some benchmarks from a chronic pain trial. But of course, if you're working with seriously ill adults who are expected to die within the next 6 months or 1 year, your benchmarks are going to be very different. So when you're setting these benchmarks, it's really important to look at the literature and to understand and learn what benchmarks other researchers doing similar research with the population have used, and try to potentially do the same or maybe a little bit better. A little bit more about mechanisms. So many interventions that we develop are multi-component interventions and teach a variety of skills. And testing mechanisms allows us to identify the active ingredients of the intervention. This is really important because it helps us develop the most economical and cost-effective intervention, and also the most potent intervention. This also supports fidelity and increases chances for effectiveness, implementation, and dissemination. And this is, again, very much stressed in the newly released NIH stage model, updated stage model, that across all stages of the intervention development, we need to think about mechanisms and even test mechanisms. So in stage 0, we hypothesize the mechanism. In stage 1, we assess for target engagement, so whether our intervention can modify the potential mechanistic target. In stage 2, 3, and 4, we do formal tests of mediation or moderations. And then in stage 5, when we're doing implementation, we test for potential mechanisms for the implementation of that intervention in the particular setting. The measures we are used to capture, we are using to capture our targets as well as our outcomes are also very important. And the PCRC has wonderful resources around what measures to use. So we know we need to have valid, reliable measures that capture the population needs. We need to have measures that are easy to understand. It's very helpful to collect feedback on measures during stage 1, so during exit interviews. It's also very helpful early on to use multiple measures for the same construct. And it's really, really important to ensure that the intervention teaches the specific skills as captured by the measure. And I think a lot of the null trials in palliative care, I think they're actually great trials, but potentially have shown no effects because the measures were not really mapped onto how the intervention was developed. And let me give you an example. A lot of the interventions that we've developed teach mindfulness as a skill. And there are many skills that assess mindfulness, and there are many ways to define mindfulness. And some of these skills are focused on what we call present moment awareness. Some are called on what we call, some are measuring something that we call decentering, which is stepping outside of your mental events. And showing improvement in mindfulness really requires that we teach mindfulness in the way we are measuring it. So in our studies, we tend to use the 5 facets mindfulness questionnaire, which has 5 subscales: observe, describe, act with awareness, and non-judging, actually 4. So we teach mindfulness with this stoplight, where red is observe. So we're teaching participants to notice what they are thinking and feeling and be non-judgmental about that process. Then we teach them to describe what they're experiencing, and again, to be non-judgmental about that process, and then act with awareness. So in this way, because we are using a scale that is mapped onto how we're teaching mindfulness, we can increase the chances of target engagement, of really showing that our intervention is changing mindfulness, as opposed to if we were using a very different scale. So now I'm going to move on and guide you through an example of an intervention developed by our interdisciplinary team at the Massachusetts General Hospital called Recovering Together. This intervention aims to prevent chronic emotional distress among dyads of persons with an acute brain injury and their family caregivers. And this intervention was driven by clinical observations that were brought to us by the chief of the neuro ICU. So he shared that many patients and families experience emotional distress, that patients with emotional distress make poor recoveries, and that current standard of care is unable to address emotional distress. And these clinical observations led to research questions such as, what are the rates of emotional distress in patients and families? In other words, how big is this problem? What are the risk and resiliency factors? What is the trajectory of emotional distress? So is it that people experience the stress and then they get better, or is the stress getting worse over time, or it's remaining stable? How can we identify individuals at risk for poor outcomes so that we don't give an intervention to every single person, including those who might not need the intervention? And how can we develop a resilient intervention that is going to be feasible, accepted, and efficacious, and eventually can be implemented in this setting? So we designed a prospective study that followed patients and caregivers for 6 months. And we learned that rates of emotional distress are high in patients and caregivers and remain constant over time. We also learned that if one member of the dyad experiences distress, it is likely that the other member will experience distress over time. We also learned that distress and resiliency factors like mindfulness, coping, and interpersonal interactions are interdependent between patients and caregivers, such that my distress impacts my partner's distress over time and vice versa. So these findings supported the need for a dyadic intervention, supported the need for early interventions that target dyads at risk, supports our potential mechanistic targets of mindfulness, coping, dyadic interpersonal interactions. They also allowed us to develop and build infrastructure within the neuro ICU, which was really, really important. And allows us to think through what theoretical models or theoretical frameworks we might use to develop our intervention. And so for this particular intervention, we used elements from the response shift framework of adaptation to acute illness, which specified that when faced with life-threatening medical events, individuals need to shift how they conceptualize their own life values as well as their activities. We use elements from the strengths and vulnerability model, which states that within dyads, each partner has their own strengths as well as their own vulnerabilities in how they cope. We used elements from the resiliency framework, which shows that resiliency factors support adaptation to stressful or traumatic events. And we use the interdependency model, which specifies that patient and caregiver factors tend to be interdependent over time. So we moved to stage 1A, where we conducted weekly interdisciplinary meetings to develop our focus group script. And our qualitative interview scripts. We conducted dyadic interviews with 24 dyads. We used this information to develop an outline for the manual. We next conducted focus groups with nurses, 3 focus groups, and also gave presentations to neurocritical care doctors. We put all this information together and developed the first version of the Recovering Together intervention, as well as our recruitment protocol for the open pilot. We next conducted an open pilot, a really small open pilot with just 2 dyads. I recommend doing at least 5, if not 10 people in your open pilot. We were restricted by funding, and conducted also exit interviews at the end. and refine the intervention as well as our recruitment protocol and in preparation for our pilot RCT. So on the right-hand side, you see the content of the interventions, all the sessions in the manual. Recovering Together is a tailored intervention that has 2 general models that are delivered in the ICU to patients and caregivers. And then after discharge, there are 4 sessions that are delivered through live video that are selected out of 5 in collaboration with the study clinician. And it's really important to mention that we didn't come up with any new skills. Rather, we use simplified evidence-based skills from dialectical behavioral therapy and mindfulness-based therapy. We also used modified and simplified cognitive skills and behavioral skills after discharge, where patients were much better able to participate in these higher level skills. We also, based on feedback from the open pilot and the nursing team, we developed a web platform with voiceover videos as well as additional recordings to support our patients and caregivers in practicing our skills. Next, we conducted stage 1B, which was a pilot randomized control trial of the Recovering Together intervention versus an educational control. And really the goal here was to meet our feasibility benchmarks. And you can see on the left-hand side that we met our feasibility benchmarks. Really important was that when you look at satisfaction, credibility, and expectancy, the rates were similar between intervention and control. And this was really important because it showed that we were able to control for a placebo effect. So the dyads randomized to intervention didn't know that they were getting the intervention, or those in the control didn't know that they were getting the control instead of the intervention. And then on the right-hand side, you see an example for improvement in outcome for our outcome of anxiety. We also looked at emotional distress and post-traumatic stress, as well as intervention targets, and results are similar. We were able to show pretty drastic improvements in outcomes for both patients and caregivers between baseline and post-test. And generally, these improvements maintain over the course of our follow-up. So pretty strong results for our pilot study. So now we are conducting with funding from an R01, we are conducting a hybrid efficacy effectiveness trial. And really the goal here is to see whether we can replicate the results within a fully powered RCT, whether we can enroll a sample that is more diverse. This was a clear limitation for our pilot study. We want to see if we find any differences in improvement by clinical and demographic variables, whether improvements in outcomes are explained by improvements in our treatment targets, meditation, this is the conceptual model that we started developing in stage 0 and we refined over time, and we will be able to formally test in our trial. So we are hypothesizing that improvement in the intervention is going to occur through mindfulness, coping, and social support, as well as positive dyadic interactions between patient and caregiver. And through these factors, we will see improvement in anxiety, depression, and PTSD, and eventually in quality of life at the level of the patient, caregiver, as well as at the level of the dyad. So what are the next steps? We don't know yet. So we may be doing a multi-site hybrid effectiveness implementation type 1, where we will try to replicate results across other neuro ICUs. We will also, if we're doing this study, we will look at barriers and facilitators to implementation across neuro ICUs. or we may need to return to stage 1. For example, if we find that we don't have support in this larger trial for one of our mechanistic targets, and we may want to remove that from the intervention to increase potency. In addition, we are working to develop a mobile application for Recovering Together, simply because, as we all know, it takes a long time from the moment you develop an intervention to the moment when that intervention is disseminated. And so based on the pilot study, we have some confidence in this intervention. And really my dream is to have this intervention as a mobile app available free to all who need the intervention. So as we worked on Recovering Together, we started thinking about how we can apply this dyadic model to other diseases. And we know that many terminal and curable diseases like neurodegenerative illnesses are associated with substantial emotional distress at diagnosis. And addressing this early emotional distress might help individuals better engage in long-term care planning, as well as prepare to cope with symptoms progression. And so we developed a transdiagnostic framework for early dyadic interventions for neurodegenerative diseases. And several mentees are executing or preparing care words to adapt to Recovering Together for other neurodegenerative diseases. So Dr. Sarah Bannon, very exciting. She's received her Notice of Grant Award, and she's working with myself and Christine to adapt Recovering Together and develop Resilient Together dementia to be delivered early after diagnosis. Dr. Christina Rush is working on preparing a K23 to do the same for ALS. Dr. Hina Manglani is taking this a step farther. She's interested in triadic interventions, as well as developing what she calls whole-mates intervention for MS, where she's trying to prevent emotional distress, but also teach lifestyle behaviors. And similarly, other mentees are adapting Recovering Together for other illnesses. For example, Dr. Alex Prosciutti is doing work in cardiac arrest. Dr. Evan Please is doing work with dyads of older adults in SNPs. And Dr. Vicky Grunberg is awaiting her Notice of Grant Award to adapt Recovering Together for parents who have infants in the neonatal ICU. And so all these interventions target core transdiagnostic mechanisms of emotional regulation, communication, and symptom management that are common across all these conditions. And of course, each program will have additional tailoring to address specific population concerns and symptoms. But very importantly, they will all address this transdiagnostic mechanism. And this is very much stressed now by the revised NIH stage model, because it really allows for wider dissemination, particularly when we're thinking about neurodegenerative illnesses, where a lot of providers are not necessarily fully specialized to work just with dementia or ALS, particularly when we're talking about social workers or nurses who might actually end up delivering these interventions. Some additional thoughts. The process of intervention development is a lot of fun. It allows you to be extremely creative, and it's also very challenging. And I truly believe that the best way to learn is by working with others who have done this for many years. I'm thinking perhaps starting this work as a research assistant, maybe moving and doing this work as a postdoc. As an early career person, being a co-investigator before being a PI yourself, and maybe doing an intervention development as part of a K. I think that courses and lectures are important, and I'm kind of throwing myself under the bus right now, but I definitely think that experiential learning is so much more important, because you learn a lot of skills that you can learn, sort of a 1-hour course or even a 1-year course. Things like building teams and managing and working through conflicts and sort of problem solving on the spot, which in a feasibility trials, I think almost every day something comes up. And also being able to think ahead and try to prevent some of the things that may be happening, some of the roadblocks. I also think it's very important to keep up with the field and not get stuck. Methodology is changing rapidly. We are not developing interventions today the way we used to develop them 10 years ago. In fact, I really cringe when I think about how I used to develop interventions 10 years ago. We're definitely much better. We also have incredible advances in technology and engineering that we can borrow from for our intervention development process. I also strongly believe in team science and having multiple PIs and a variety of stakeholders, interdisciplinary stakeholders, particularly when we're talking about palliative care interventions. And, you know, as a psychologist, I said I'm probably very biased, but I really believe that having a social psychologist or a clinical psychologist or a nurse scientist on the team is going to be really, really important. So a last word about the state of the science. As I mentioned earlier, with a revised NIH model, it's really, really important to focus on mechanisms of change across all stages. It's really important now to focus on implementation from early development. A lot of the times now, people use elements of implementation processes or implementation frameworks as they develop the intervention to facilitate the eventual implementation of the intervention, peer support interventions, as well as using lay coaches for intervention delivery is becoming much more popular because it's so cost effective. Smart and most designs are great to develop the most efficient and cost-effective interventions. And the PCRC had two wonderful lectures that I'd encourage you to listen to. Tammy Sommers talked about smart designs, and I think last month, Nick Autumn talked about the most designs. We're seeing user-centered designs frameworks taken over. This have been used for a long time in mobile application development, and definitely we're seeing a trend for this to be used across intervention development process. I think this is great. They're very efficient. One challenge is that they don't always account for mechanisms. So I think this is really, really important to keep that in mind. Also, we're moving away from in-person interventions toward virtual interventions or remote interventions or coaching interventions or the use of apps. And we are entering the era of behavioral health. This is really, really exciting for someone like me. For the longest time, National Institute of Health has been prioritizing biomedical science. And so it's really, really great that I'm seeing more and more funding going right now toward the development and implementation of behavioral interventions. So I hope that I was able to convey that behavioral intervention should be part of regular care for people on the continuum from health to illness, that behavioral intervention development for patients with medical illness or caregivers requires interdisciplinary collaborations, frameworks, theory, conceptual models, feedback from all stakeholders, focus on hypothesizing and testing mechanisms, focus on implementation from early phases, and careful selection and mapping of measures. And as I said before, experiential learning is important. There are lots of bumps along the way, and it really helps to navigate them with someone who has done this before. So as I end, I want to draw attention to some resources that are incredibly helpful. So the Science of Behavior Change has just really wonderful resources in terms of, mechanisms and measures. And then the revised NIH stage model, there's a wonderful, almost 2-hour video that really guides you through what you really need to do to develop interventions. And it's really, really useful. So I'm going to end here. Thanking you very much for spending this time with me. And I am very happy to take questions.
Thank you, Dr. Vranceanu. That was amazing, and loved all the illustrations based on your own work. It's really, I think, helpful for people to get an example of how to actually implement some of these approaches, and especially thinking and paying attention to mechanisms. So we have one question so far, and please, for those of you who are with us, please feel free to put additional questions in the chat. Thanks for your wonderful presentation. How many patients were included in your pilot randomized trial with the results that you presented?
Yes, so we had, I think we started with 63 people and we had 58 completers. And these were 58 dyads. Yeah, and this is really I mean, when you're thinking about a pilot sort of stage 1B, it's really between, I would say you want to have no less than 20 completers. The closer you get to 30 completers per arm, the better. The more stable your results, your means and standard deviations are going to be. So the more confidence you have that results may maintain in your future trial.
Awesome. Another question. You have a goal of recruiting more diverse populations in future stages. If you could go back and address this at an earlier stage, what would you have done?
That is a great question. I think I would have had more funding so that I could actually do the things that we're trying to do now, which are really prioritizing approaching every single underrepresented minoritized population that's seen in our neuro ICU. Unfortunately, some of you may not know, because when we think of Boston, we think of a sort of a very diverse population, but unfortunately, the Massachusetts General Hospital population in the neuro ICU is primarily white. And so I think we are in our R01, I think we have about 25 dyads enrolled so far, and I think we're doing pretty well, much better with our diversity, but it really is a struggle. With more funding, I would have also loved to put together a community advisory board, to be able to look over the materials. I definitely think that's really, really important to do. This is one of the challenges with the small trials is that in order to do really, really good work, you need more funding, but the R21s give you so little funding that it's just really harder to do all this work.
Thank you. Another question for you is, what questions do you ask as part of your exit survey? Do you have any sort of tried and true questions that you like?
Yes, so we develop a qualitative script, and really the goal here is to build upon your satisfaction, the sort of quantitative satisfaction questions that you give people at the end, right? So for example, if you have people who say maybe they didn't like the intervention, sort of being able to probe around that, like what were some of the things that you didn't like? What were some of the things that you liked? What did you think of the measures? What did you think of how we taught the skills of mindfulness, or how we taught interpersonal communication? Did that resonate to you? What feedback do you have? So anything that you can sort of build qualitatively on the quantitative data that you collected, so that you can maybe eliminate some measures, or maybe think about, maybe I taught mindfulness in a way that just didn't resonate to people. How can we teach it in a different way, for our trial, so that we can ensure that, our participants are going to actually benefit from this skill. And really, this is how we went from, our first version of the manual, which had, much complex language, to our version now, where everything is so simple. And we also have these voiceover videos where, patients and caregivers can actually visualize an explanation of the skills in a very, very simple manner.
Great, thanks. Another question for you is, could you share your thoughts on balancing having diverse populations while also being mindful to the different needs of different racial and cultural populations? And could that be potentially tricky in a pilot?
Yes, it can be really tricky for sure. I think that kind of going back to mechanisms, right? Like those transdiagnostic mechanism, I think that when we think about a neurodegenerative illness, or when we think about an acute brain injury or a stroke, right? Those transdiagnostic mechanisms of emotional distress and communication and social support, right? They're going to cut across, all humans, right? And so, I think that being mindful of those mechanisms, and then thinking a little bit about how to make teaching the skills that address these constructs to make sense for for everyone, for various racial and ethnic minorities. What I love to do is I love administrative supplements or diversity supplements to any type of grant. I had R21s and R34s with supplements, because they really allow you to actually have more funding and also support other investigators, ideally from a minoritized backgrounds, with a diversity supplement, to really be able to do this work and allow us to understand, can we deliver the same intervention that is very much tailored to different groups or not? Because ideally, we do want to develop interventions that can apply to all populations, regardless of their racial and ethnic background or minoritized status.
Awesome. Can you speak to whether and when to specify non-inferiority, superiority, or equivalence in the context of behavioral intervention trials?
Yes, right. So I think it really depends on how many interventions are available for that population, and whether there are any interventions developed for that population, right? So for example, if, let's say, I'm looking at, CBT for depression, we know CBT works well for depression. If I'm developing another intervention, then maybe I do want to show that is non-inferior to CBT, right? Because we know CBT works. If we have an intervention that maybe doesn't work really well, but it's the only intervention that we have, then maybe I want to show that my intervention is going to do even better. So I'm going to try to show superiority. We haven't gotten a chance to talk about control group. I think that that's like sort of another PCRC webinar that, someone can do, but, the choice of control is really tricky, and it really goes into these conversations around the type of trial that you want to do.
So another question is, this person has been talking to a lot of researchers in pragmatic trial stages who've mentioned the difficulty of assessing their outcomes pragmatically. So can you say more about how you've approached pragmatic assessment of your outcomes as you move towards the implementation side of things and interventions?
Yeah, this is really, really tricky, because I think that, I think it depends on the sort of particular hospital setting and the type of measures that they are using, sort of, as part of the electronic medical record. We haven't thought that far, in terms of, how are we going to actually implement the measures that we're using? How are we going to, make screening for depression and anxiety or emotional distress automatic? Particularly because we don't like the PHQ measure, which is the measure that most hospitals like. A lot of our patients gave us feedback that they don't like that measure. The items are not very patient-centered, so we're using the hospital anxiety and depression scale. And so, we will have to think about this for sure for the next trial. Because this is a really, really important question.
Indeed. So last question before we conclude, and this question is, in pilot testing, what are the pros and cons for 2 test arms versus a single test arm?
Okay, where is Greg Samsa, right? Or other PCRC statisticians? I honestly will not take the risk of answering these questions and giving you the wrong answer. Something that happens as you sort of advance in your career is that you cannot do everything. And so I haven't done my statistics in a very long time. I really leave this to the people who spend most of their time doing their statistics. And so I can find this, I can connect this person with someone else, or even with some of the wonderful statisticians at PCRC.
And maybe, Anna Maria, I can just offer one thing, which is, in open pilots, a lot of times you don't have a control arm and it's just one arm. And however, if you're really wanting to test a randomized controlled trial sort of design, then it is useful to have two arms. And so I think trying to sort of understand to what Anna Maria spoke about earlier, where you are in your own sort of implementation journey and where you are in the stage model may help you decide whether or not a single test is acceptable or whether or not you really need to have a true control.
Right. So yeah. So I think if you're looking at the open pilot, if you're trying to decide if you're doing an open pilot with no control versus a randomized trial, I think you need to do both. I strongly believe that before you're doing an efficacy trial, please do the randomized control trial with your control, because a lot of the times you find out that you can't randomize people, that they're just not gonna, you're not gonna be able to collect a follow-up. Definitely go through the stages, 1A open pilot, 1B, the sort of pilot RCT.
Awesome. Well, thank you for an incredibly instructive webinar and for this time together. I think a lot of people got some very good tips and pearls for their work. And I'll turn it over to you, Naomi, for any final announcements.
Thank you so much, Dr. Vranceanu, and thank you so much, Dr. Ritchie, for joining today. I just wanted to quickly go over our next upcoming webinar. So next month, we have Dr. Hilary Blum presenting on engaging key partners in palliative care research under the hood of co-creation work. And then in November, we have the PCRC's very own Dr. Jean Kuttner presenting on how to build a research shop. So please do go to our website and register to attend those. Slides and recordings are also posted on the website, so you'll see a link to that. And lastly, there will be a post evaluation for today's webinar, just to let us know how we did and to suggest future topics. And with that, thank you everyone so much, and we'll see you next month. Take care.